Sure. Okay, thanks so much. Hi, everybody. We're going to go ahead and get started with the next session. I hope everybody's enjoyed their morning so far. And it looks like a great lunch. My name is Allison Lofthouse. I'm the Assistant Dean for Global Health at the School of Public Health. We're really excited for this session titled Beyond the Exam Room, Breaking Down Silos and Leveraging Partnerships in Refugee Health. And this session is dedicated to the observance of World Health Day. In case you didn't know, today's World Health Day, so happy World Health Day. With us today, we have two fantastic speakers. I'm going to go ahead and introduce them, Dr. Jahan Adamji, as well as Ms. Rebecca Larson. So first, Dr. Jahan Adamji is the Clinical Director of Refugee and Immigrant Health and a family nurse practitioner at Tapestry 360 Health, formerly Heartland Health Centers. Dr. Adamji earned a BA in Anthropology from Macalester College, a BSN and Master of Science in Nursing, Family Nurse Practitioner in Nursing from Rush University. And her doctorate she obtained from Johns Hopkins. Throughout her career, Dr. Adamji has leveraged her interactions with individual patients and families to inform initiatives at the community and health systems level. She was introduced to caring for newly resettled refugee populations during her first position as a family nurse practitioner at HHC's Uptown location. After 7 years providing refugee health screenings and primary care to newcomers in Baltimore, Dr. Adamji returned to Tapestry 360 Health in 2021 to expand the organization's immigrant and refugee programs. Under her leadership, Tapestry 360 Health has become a leading refugee healthcare provider in the area based on a multi-level integrated approach to care. Relying on strategic and sustainable academic and community partnerships, the program addresses the complex barriers and inequities impacting newcomer populations. So welcome, Dr. Adamji. And with her today is Ms. Rebecca Larson. She is the Family Case Management Program Manager at World Relief here in Chicago, where she's worked for 6 years. She supports case management programming for especially vulnerable refugees, asylum seekers, and refugee seniors. Please join me in welcoming them.
Thank you, Dr. Lofthouse, for that introduction. And it's a pleasure to be here today to speak with you all. I'm really grateful to have Rebecca Larson join me in this discussion and conversation. The ambition for today is to understand the context of refugee healthcare in the United States and Chicago, to discuss the challenges in caring for refugee populations and opportunities that exist through partnerships and collaboration, and at the end to offer a multidisciplinary community-based vision for the future of refugee health programming in Chicago. I have no financial disclosures. I do want to acknowledge a few organizations and institutions. First, Tapestry 360 Health is a federally qualified health center on the north side of Chicago. We serve thousands of patients a day in those communities, and really grateful for the opportunity to come back to the north side of Chicago and support refugee programming and grow the program at Tapestry. Also, IDHS and IDPH have given us the funding to do this work in a meaningful way, and we're really grateful for that opportunity. And also, want to thank all the staff and colleagues working both at Tapestry 360 Health and in our refugee network to support our newcomers. And finally, I had an opportunity this January to work with Dr. Sage Kim and Emily Steele from UIC, who reminded me in our group as we were working on a 10-year plan proposal to the NIH to always ground the vision that we have and the work that we do in evidence-based outcomes and goal-driven measures as we innovate to meet the needs of vulnerable populations. So I really appreciated that experience. A little bit about me and my immigrant background. My father is from Zanzibar, an island off the coast of Tanzania, and my mom's roots are from Poland and Ireland. They actually met at Illinois Masonic Hospital in the 1970s, which is where my brothers and I were born also. And I have the privilege to travel 7 hours south of Santiago, Chile, every year with my two sons to spend some time with our extended family there, where my husband is from. So my immigrant history and my family's immigrant history really brings up this question of why people voluntarily migrate. So, in my case, in my family's case, for the most part, with some push factors present, we're pulled to the US for economic opportunities, educational opportunities, programs and institutions here. But the populations we're talking about today are those who have been really pushed and displaced from their homes due to poverty, being victims of persecution based on race, religion, ethnicity, war, and other disasters, and less on pull factors. And so it's really important to distinguish those real founded reasons for migration. So just want to talk a little bit more and define the population we're talking about today, because I think there's a lot of confusion when we use the word refugee. So I'm in these 4 immigrant categories I'm throwing on the screen. I want to know in the room, how many of you are familiar with, really confident with the definition of all 4 of these terms? Okay, I see a few hands raised. How about 3 out of 4? Okay, 2 out of 4? How about just 1? Okay, so 2 out of 4 seem to be the winner there. And I'll talk about each category a little bit, but who we're talking about today are groups that in immigrant categories who have been granted legal admission to the United States for reasons of special humanitarian concern. And so these folks are eligible for Office of Refugee Resettlement programming. And we're going to talk about what that programming looks like. It's important to note that we're not talking about people who come with other types of visa, under other visa programs, those with temporary protected status, or those who are coming over and do not have legal status. And so we use the word refugee a lot to talk about all of these groups that flee to the United States, but for today's talk, we're really just focused on these specific populations. So the legal definition of refugee is one who has been persecuted for UN Convention reasons, usually race, religion, nationality, membership of a particular social group or political opinion, are outside of their own country with no protection and a well-founded fear of returning. In order to apply for legal refugee status, you must be outside of the United States and then enter with that legal refugee status. This process is long, and we'll talk a little bit about it later. Asylee is a bit different. So these are populations who cross the border and seek asylum. So they cross usually without legal status, undocumented, and make the case that they, meet the definition of refugee. So again, displaced from home for UN Convention reasons with a well-founded fear of returning. But until they obtain asylee status, which can take a very long time, they're considered asylum seekers and are not eligible for the programming in the program that's funded by Office of Refugee Resettlement. And it's really important to talk about the last couple of years which has sort of brought a rebirth of this humanitarian parolee category. These are individuals who would otherwise be inadmissible for legal entry to the United States, but are allowed to come in for a temporary period of time because of urgent humanitarian concern. So here we're talking about Ukrainians and Afghans, given the what was happening in their home country, war, and the U.S., leaving from Afghanistan. A large number of families we've served lately have been Afghan or Ukrainian parolees. I want to talk a little bit about recent refugee resettlement patterns to give a little bit more of a glimpse of who we're talking about today. On this slide, again, these are just refugees that we're talking about, legal definition of refugees, so not the other groups that I mentioned before. The blue line indicates the annual ceiling that the president places on refugee resettlement, the numbers that would be allowed into the country, and the orange line represents those numbers who have been admitted. As you can see, over the last 23 years or so, those numbers, both lines have fluctuated quite a bit based on, policy, who's in leadership, and other factors that, take priority. And as you can see in the last couple of years, we have admitted much fewer than have been set as the ceiling. And we're at pretty much an all-time low historically. So which countries do our refugees come from? In 2022 in the United States, you can see our top 10 countries there: Democratic Republic of Congo, Syria, Burma or Myanmar, Sudan, and then a handful of other countries follow. And in Illinois, since September through February, similar countries listed as the leading countries of origin. So DRC, Burma or Myanmar, Syria, and then a handful of Central and South American countries, including Honduras, Venezuela, and Colombia. Depending on country of origin and sort of the experiences leading up to obtaining refugee status and resettling, as well as what category one fits in under Office of Refugee Resettlement Programming, refugee journey can be very different from one person to the next, from one family member to the next. But there are some trends that we see and similarities between groups. To put this into context a little, we're gonna meet a fictional patient of ours, a refugee from Myanmar. He's a Rohingya refugee. Chicago is home to thousands of Rohingya. They've been stateless in Myanmar or Burma since the 1980s and victims of multiple crimes against humanity and genocidal acts since. Abul Sultan traveled to Bangladesh 15 years ago and took a boat to Malaysia, where he applied for refugee status with the UN and was resettled this summer in Chicago. The process overseas when applying for refugee status is long. A few years ago, we were saying on average 13 years, but we believe there's reason to believe that number of years is actually longer. And many steps along the way, starting with the UNHCR, a lot of US institutions applying vetting process, and eventually arriving in the United States. And on this picture, it seems like the journey ends at arrival, but we know that that is not the case for most. And so, wanting to acknowledge, School of Public Health, very familiar with the structural factors and social determinants of health that impact outcomes, but both pre and post-migration setting, social determinants of health are a major player, as well as the exposure to trauma in the pre, intra, and post-migration stage of this journey. Post-migration stressors are both Rebecca and I work to mitigate and support our refugees. So what do we do to support these new arrivals? We're going to talk a little bit about this now. In Chicago, Tapestry 360 Health is one of 2 refugee health screening providers. We've been doing this since January of 2022, and Sinai and Tia's Clinic is another, has been at this work for at least a decade. In the suburbs, there's a couple other federally qualified health centers that have been contracted by the state to do this work. And in Chicago, there are 6 resettlement agencies helping support the resettlement process. It's important to note there's dozens of other organizations that support these populations, other healthcare providers, specialists, community-based organizations, behavioral health organizations, neighborhood associations. Some have ORR programming and funds, and others are just community-based. So what happens inside the exam room? What is this refugee health screening? Each refugee who comes through Office of Refugee Resettlement is expected to undergo a comprehensive medical screening within 90 days of arrival, ideally within 30 days. We follow CDC guidance. DHS contracts us. IDPH monitors our performance benchmarks. It's an opportunity to identify health issues, promote well-being, and orient new arrivals to the U.S. healthcare system. It's really the introduction to the healthcare system at the initial stages of resettlement. And at this visit, it's very comprehensive. We screen for a wide range of infectious and non-infectious diseases, full history and physical, mental health screen, provide vaccines, and get kids ready for school, and sort of prep for the green card process that happens about a year later for most. Patient-centered approach. The goal is to build trust, given many refugees, have not trusted the system, so to speak, especially when it comes to their healthcare in the past. And the idea is that an expectation is that we refer all those we screen for primary care. And so you can imagine this visit looks very different for both the refugee family and the healthcare provider. The context under which we provide this exam is very different. Very big families come to see us. Our clinic looks very different to them. We use interpretation the whole time. Families are there for, 4 hours. We're pulling adults out for their confidential conversation, and some of the older teens, working with a large team to support their care from the point of check-in to the point of check-out. Mentioned the primary care being an integral component of this screening and making sure folks are linked to ongoing care. Tapestry 360 Health, formerly Heartland Health Centers, happens to have locations that are embedded in these refugee communities where a lot of the families have rental properties and live. So we have naturally become the primary care provider for the majority of the participants that we screen. And as you can see, 92% have, live in zip codes where we have primary care clinics and services available. So what happens in the primary care setting? We, as mentioned before, addressing psychological distress and the development of common mental health disorders, anxiety, depression, PTSD. We see a lot of chronic pain and other functional disorders that are impacted by those diagnoses and distress. Continuous management of infectious disease and chronic disease that have either been long-standing or newly diagnosed. We are referring to specialists regularly, acknowledging that many of these refugees haven't had specialist consultations to manage some of the more complex issues they have. We're planning for preventive care, making sure there's awareness over cancer screenings, regular annual visits, and vaccines. Women's health services include prenatal care for those who are pregnant, and family planning for those who want to prevent pregnancy. And there's a great need for dental services as well. All of that work is heavily impacted, and the success at which we're being able to manage those issues is heavily impacted by what's happening outside the exam room. And so I invite Rebecca to come up and talk a little bit about that.
Thank you, Jehan. So every refugee who arrives to the United States is formally matched with a resettlement agency prior to their arrival. And there's a very core set of services that those agencies need to provide within the first 90 days. And so those look pretty similar across resettlement agencies. So I'm going to just give you an idea of kind of the very basics of what those are through the Reception and Placement Program, it's called, or RNP. So resettlement agencies pick people up from the airport, provide them with a warm, culturally appropriate meal. They help them to find housing that is safe and affordable, ideally, which is always a challenge, and hopefully in communities where, or areas where people will quickly find community. They help provide food for the first week, help people to apply for their Social Security cards, medical, cash assistance, food stamps, other benefits that might be appropriate in their situation. They help refugees get enrolled in English language classes, either in-house or externally, help children to get enrolled in school. Most resettlement agencies have employment programs in-house that help people to find jobs, often entry-level jobs right away, and then sometimes more career advancement type services after that. They help people to file change of address forms, get to and schedule their health screenings that Jahan was talking about, and follow-up care. And then in addition to just providing people with those services, we want people to have the best understanding they can of the systems that they're needing to navigate, so that they'll be able to do them as independently as possible. So we provide orientation to U.S. culture broadly, to healthcare in the U.S. using CTA, to how English language programs work, employment, and education. And then beyond those first 90 days, the services that refugees are offered through resettlement agencies really vary depending on the needs and the interests of each family, as well as the unique specialization and resources of each resettlement agency. And we do definitely refer between resettlement agencies and community organizations to try to make sure people are getting the best services. These are some of the programs that World Relief has, in addition to that, those core services in the first 90 days that are a bit more focused on health. We have a preferred communities program that's designed to help especially vulnerable refugees and asylees to reach self-sufficiency. So some of those examples of vulnerabilities are people who have a disability or chronic health condition, or a single parent or survivor of gender-based violence. And yeah, that emphasis on self-sufficiency is so important, helping people to gain skills and get connected with resources apart from the resettlement agency. We have a new program we're excited about for refugee seniors through the RSS grant that provides case management and group services and outings to help try and reduce social isolation for seniors. We have a Building Healthy Communities program through Cook County Department of Health that helps support the workshops that we provide around health for refugees in partnership with some other organizations. An Illinois Federal Resource Program through the Southern Border Assistance Program to serve asylum seekers with healthcare and other things. We have a health advocate volunteer program. So these health advocates help people to get to their appointments, provide advocacy for them in them, and understand follow-up care, a host of other types of volunteers. So through all these programs and others, we're trying to provide extended group-based services, healthcare orientation, and linkage to services and care wherever we can that are culturally and linguistically appropriate. So these things that we've been talking about so far are some of the things that we try to do to help refugees to access the healthcare that they need and reach stability in their health. But there continue to be so many barriers that these populations face toward accessing healthcare. So we're going to talk about those for a bit. Depending on the context that people are coming from, some arrive with a really limited understanding of longstanding medical conditions because of lack of access to healthcare in a refugee camp or home country. As we know, the health insurance system here in the US is very complicated, even often for those of us who were born here, and just difficult to navigate and sometimes changing. Language access is huge, from making the phone call to schedule your appointment to the appointment itself. Most of the documents that are provided to you after the appointment or during are in English, and many of our clients are not literate in their first language, and so even if they are translated, that's a difficulty. So it makes it a real challenge to, on your own, be able to follow up on instructions that the doctor is giving to you. Transportation barriers are significant, sometimes because of financial limitations or mental health challenges that make it difficult to maybe feel safe riding the bus or to remember the route, and also disabilities that can make it difficult to access public transportation. Mental health and the effects of trauma can just make it more difficult to remember appointments, all the things you need to bring with you to navigate that system, and results in a lot of somatic complaints that are harder for providers to diagnose and know how best to treat. Newcomers to the US often have entry-level jobs that are not very supportive in giving people time off for healthcare appointments, so that's a challenge. Many are in need of healthcare but don't yet have a trusted network of people who can watch their children while they go to the doctor. And there's also sometimes a lack of comfort and trust with this new medical system, and it can feel very intimidating, and people can feel unsure of what their role as a healthcare consumer should be in these appointments. For example, is it okay for me to raise a question or concern that I have during my doctor appointment, or should I just be answering the questions that the doctor asked me? And many people sometimes are coming with limited health literacy and also digital literacy. And digital literacy was a really acute problem during the height of COVID, but still is important, as some providers are only offering telehealth, especially for some types of visits. Yeah, back to Jehan. Thank you.
Thanks, Rebecca. So Rebecca just provided some of the patient level barriers and the barriers they face in advocating and supporting patients. But the healthcare system, as you can imagine, based on all of those barriers, can also have a lot of challenges in meeting the needs of this population, both the provider, the care team, and the system itself. So as mentioned, some of these complex needs, perhaps previously unaddressed, you're starting from square one in a 50-year-old. Or treated with a different approach overseas. So you could have a bag of meds from another country and just trying to figure out what was going on and what the diagnoses were based on the bag of meds in front of you. There are a limited number of resources for linguistically appropriate mental health resources, but also those that are sort of culturally accepted. So, therapy might not be something that is appropriate for many of our refugee populations, but other interventions to address the mental health needs that exist. Many of these health needs are intersected with the impact of trauma, structural factors, social determinants of health, as mentioned. As you can imagine, when you have an interpreter and you have someone with limited literacy and health navigation skills, those visits are long. And interpretation is not reimbursed. So as you're trying to grow a program to support the needs of limited English proficient patients, but you don't get the funding back to provide the access that's needed to interpretation, figuring out how to sustain a program like that is something that we are working hard to, we're working hard on that. And it is expensive to serve this population. This is a really diverse population. One day you could have a family of 8 from Congo, the next a family of 12 from Afghanistan, and tomorrow a family of 3 from who speaks Rohingya population. So, learning not only the expertise in these cultures and communities and histories, but also having the diversity in support makes the needed resources pretty expansive. As many of you know, and are probably either studying or working to mitigate this fragmentation in our system, both at the healthcare system level and, in social services and education and employment, there's so much fragmentation. So you might have a patient come to you after visiting a specialist office. They don't remember the plan of care. You don't know the plan of care because you don't have the report from the specialist. And when you call the specialist, they ask for release of information, even though you're the referring provider, right? So you really need to work hard to get the information. And we also, unless you work closely with the caseworkers and community-based providers, don't really get a good sense of what's happening in the community with these patients or in the homes. But then they come to you with those concerns, paying rent and getting a job. But as healthcare providers, that's not something we have in our wheelhouse yet. So that fragmentation can be really challenging. Of course, the cultural understanding in the variation in how we understand illness in refugee populations versus, Western medicine. And just learning that this really requires a robust care team in an ongoing fashion to meet the needs. Some of our patients become quite independent quickly based on a number of factors, but so many require a little bit more hand-holding for a prolonged period of time in order to support them. So returning to our patient, Abul Sultan was resettled by a local resettlement agency and given some community-based support by one of the CBOs on Devon. He received his refugee health screening at Tapestry 360 Health and continues to see us for primary care. As you can see, long list of medical diagnoses. Came over from Malaysia on some medications, but having to change those to meet our formularies that are required and help him understand what those changes are. There was great fragmentation and very little communication between the healthcare providers that cared for him and the service providers. Those first 3 months he arrived, went to the emergency room 3 times. So sometimes come without his meds. We weren't sure what he was taking, or meds that were misunderstood, using 2 different pharmacies, meds with different providers' names on them. Was unable to start work due to his illnesses and could not pay rent for his family of 5. And following this most recent emergency room visit, his blood sugars were through the roof and he was really not feeling well. So what can we do to break down this fragmentation and work together and leverage those partnerships to work together? So the general approach that we've sort of embarked on is just to have regular, consistent communication that's really goal-driven. So looking at each organization's strengths and weaknesses and finding a way to strategize together with, reaching a common goal. Looking at how we're funded and what those objectives are written in those grants and see if we can share resources to meet those outcomes. Thinking about collaboration versus competition. It's really easy to be competitive when you're fighting for the same funding source, but thinking about perhaps subcontracting when agencies do get funding and you realize we can't do all of the work that's needed for this to really get driven home. And so finding an opportunity to subcontract to other agencies is something that's very valuable. Considering the expertise across different organizations and sort of have that bi-directional consultation and bi-directional referral process. Supporting staff at both, the healthcare system level and the resettlement agency or community-based organization level with education and training about various topics. And then, of course, supporting the staff that works to care for these communities and making sure they're taken care of and have attention is paid to their own wellness. So I'm going to invite Rebecca to join me for this last part of our talk. So this slide has a bunch of different current initiatives on it. So at the Tapestry 360 Health level, we really are putting together a care team that involves a care coordinator, a group of sort of refugee health providers, family practice, pediatricians, psychiatry. We have recently hired a public health nurse to join the team, and we have a sort of a senior manager who also is responsible for connecting with the external community and sort of bridging the gap there. We're thinking about including the refugee agency caseworkers and bringing them into the exam room as much as possible, and also having them be the eyes and ears out in the community to help support the care plans that we come up with. And also thinking about growing to involve refugees themselves in the care team as we are able to in the future. We are, trying to tap into some student interests in our area, medical, nursing, and probably public health schools one day, to really be part of the work that we do and help, fill in gaps that exist with the capacity that we have to do all of this work. We've also been trying to build a network of specialists who really are familiar with refugee populations, perhaps speak some of the languages that our patients speak, and can also be collaborative in communicating back with us. Tapestry 360 Health has a a group of specialists from Swedish did their transformation project at one of our, at our Albany Park clinic. And so we're beginning to try and bridge the gap there as they are internal as well. Thinking about some things that can happen with the patients themselves and our refugees, we have recently, with another resettlement agency, they organized an event to have all of the Afghans who resettled about a year ago and are kind of looking for a primary care provider close to home. They had an evening where a couple of our staff, front desk staff, went out to the agency. They provided the interpretation, they provided the linkage to care, they invited the head of household in or the families in. We're able to register on the spot, given instructions on how to get to the clinic closest to their home, and all given appointments for family members. And our public health nurse is going to outreach to them prior to the visit to find out sort of what the needs are, the pressing needs are, so that the provider seeing them for the first time, has a place to start from. We are envisioning the opportunity to do some group visits. So we would look to our resettlement agency partners to bring groups in by language or cultural background and provide some interpretation where we would be able to, like with a group of women from Afghanistan, in Dari or Pashto, talk about what a pap smear is, talk about what birth control options are. As a group, allow them to build community and kind of dispel any myths they have and fears, and then individually bring them back with the provider to either do the PAP or get them started on their birth control of choice. Rebecca's going to talk about a few other things.
So sometimes before a refugee arrives, the resettlement agency knows in advance that they have a health condition that's very acute, that's going to need urgent attention sooner than their usual health screening. So that's a time when we are so grateful for these refugee health screener clinics who can help us do some triaging prior to arrival. Last week, we at World Relief, we had a refugee arrive who had paraplegia and severe skin wounds and ulcers. So had come on the Swan flight from Malaysia. And so our doctor was able to arrange for him to be seen at the ER right away from the airport. Even though he came with no health insurance, very little medical records. And there's a surgery team that was prepared to meet with him the next day. So that's incredibly helpful. Workshops are just a tremendous way for us to partner with healthcare providers and provide critical health information in a setting that's often more comfortable and relaxed, and people can ask questions, and there's a community building component to it as well. We've done lots with Tapestry over the years. Some recent ones, we did a healthcare orientation workshop at Tapestry's clinic on Devon. So a really great way for some of our participants to see the clinic, know how to get there, get familiar with it, and just learn more about how to navigate the healthcare system. And we've had two recently, one in Kinyarwanda and one in Arabic, I think, on nutrition at World Relief's office. So Tapestry staff came there to present about nutrition in a way that was contextualized a bit for those cultures specifically. We have several coming up on blood pressure and heart health and first aid as well. And at each of those workshops, refugees have an opportunity to be linked to ongoing primary care there as well. We're also really excited about a new initiative we're planning using a curriculum developed by the WHO called the Self-Help Plus training to try to address some mental health needs. So Jahan talked about the trauma that most refugees have experienced, including just the resettlement process itself is traumatic for many. And so often our Western mental health services that are available are not particularly wanted or helpful or available. There's a real shortage of them. And so we and everyone else trying to serve refugees is trying to figure out how to bridge that gap and help refugees to gain the coping skills, self-care skills that they need apart from those interventions. So a train the trainer model where a clinician from Tapestry will come and train several of our staff at World Relief to be able to provide these trainings, 5-week series on an ongoing basis.
And there are few partnerships in the works for us at Tapestry. So we're embarking on a 3-year program with the Kovler Center called the Afghan Alliance of Greater Chicago, which will be focused on the behavioral health needs of our Afghan arrivals. We'll be the primary care provider and psychiatry provider and provide nurse case management. And the Kovler Center will be doing therapy, group therapy. And so we're just at the beginning of that. Which there's a great need with that population. We are part of Asian Health Coalition's Health Equity Through Language Access HEALS grant, also the beginning stages of that. We have been tasked by the IDPH to reinstate Illinois Refugee Health Task Force with a bit of a different vision to really think about Illinois one day being a place where refugees are getting high quality care at every level. And so we'll be gathering leaders in this work in a few weeks to start that. And also just sort of the ongoing conversations that include our academic partners to really bring this work to a different level. So we'll go back to our patient as we wrap up here. This is a patient who has great need for a PC program, intensive case management through the resettlement agency. Perhaps bringing the caseworker in during the medical visit to enroll in that program after emergency room discharge. Make sure that the plan of care and the goal setting that they do in their program have a little bit of the goal setting that the PCP has with the patient. Help make sure the medications are obtained, starting on insulin and making sure that he has all the supplies and understands how to use them. Having nurse case management to support that care at the Tapestry 360 Health level and to communicate out with our partners. Referring to dental, perhaps experts, ophthalmology and physical therapy who are knowledgeable about this population. We have talked a lot about starting a Rohingya sort of centering diabetes group as we're seeing a lot of type 2 diabetes with this population and how valuable something like that might be. Providing education in the Rohingya Cultural Center, which is one of our partner community centers on nutrition and diabetes care and prevention, perhaps enrolling him in a Self-Help Plus program at a resettlement agency, and then of course, making sure that job readiness is happening. So this last slide is a sort of a vision for what we might have in the future. We talked a little bit about what we're doing now. But I think we're going in a direction that's really exciting. And there are programs like this outside of Chicago, outside of Illinois. And so those are some of the logos up there from various states and cities that are doing this work already. But thinking about shared space, having healthcare provider work right alongside the resettlement agency. The resettlement agencies end up being this home, the second home for a lot of the refugees. And so there's a comfort there that they might not feel in coming into the clinic. So recognizing that, again, integrated care teams, access to social services while they're accessing their care, having trauma-informed expertise, thinking about workforce development and recruiting refugees to work in the healthcare field, perhaps thinking about, getting outside the walls of a center to provide home visits and mobile care, going into the schools, bringing in a collaborative of specialists, thinking about a new model of staffing that includes an interpreter that also would function as, community health work, cultural broker, having opportunities to do culturally informed wellness programs, childcare so that people can access their provider and be, have a private setting to do that. Thinking about supporting entrepreneurship and then always, grounded again in that need to be evidence-based, not just doing it because it sounds good, but doing it because it truly is what drives the outcomes that we're looking for this population. So I will take questions now. Thank you so much for your attention and interest.
So we have about 5 to 7 minutes for some questions. If you have a question, just feel free to raise your hand and Keith will come around with the microphone.
Thanks so much. That was so interesting. I learned so much. I'm thinking about refugees and other who speak languages other than the ones we know, like Spanish, that we're more accustomed to accommodating. And I'm particularly thinking about children starting schools and learning what kind of supports there are for students who don't speak English and don't have an English program.
I think most resettlement agencies have children and youth programming that helps with the school enrollment and just school support for parents, understanding about how important our pickups and communicating with teachers and those kinds of things. Schools do, they are supposed to regularly use language access, language lines for interpretation or have interpreters there available at schools. I know that's sometimes really challenging for schools given financial and time constraints. So we do some advocacy with that. Resettlement agencies also sometimes have after-school programs, summer programming, and I believe, I'm not as familiar with the children programming, but I think that most students do receive quite a bit of English language learning support through the school. Also homework tutors.
I'd say it's amazing to see a family back a year later and the kids are, speaking very, it's really, not always, but it can be really impressive.
Hi, thank you for coming again. I wanted to know, do you ever encounter issues where you have someone who came from a refugee background and they mistrust like biomedicine, like in general? And if so, how do you navigate that?
Yeah, I mean, I think it's perhaps implicit, and not so much digging, that we might need to do to arrive at that conclusion. I think that it takes a lot of time, and sort of, setting the stage and explaining the body, and explaining, why things work the way they do. I had a family of, I think 8 Congolese, and the 19-year-old had really high cholesterol and his liver enzymes were elevated. And, so I say, your cholesterol is high. And the interpreter paused and I was like, do you know what cholesterol is? Because there's not that institutional knowledge about that. And I think we also, we could do a better job sort of respecting what the understanding of illness is. And I think if we're able to, have the time and resources again to inquire and do some research on what the understandings of illness are among certain populations, we'd be able to meet the patient halfway. I don't think we do a good enough job, to be honest, but I think there's great potential there. Our nurse actually came in and was helping a Burmese patient with her blood pressure and said, so I wonder what the Burmese, understanding of high blood pressure is and what the cultural understanding is of all of this. And I my immediate reaction was, let me just get through this visit. But realize, now we've got this new, that's this kind of stuff I used to be able to think about and spend time on. And so now we've got these new members of the team and look to our resettlement agencies as we get to know and work with them a little bit better to help fill the gaps and provide that expertise. So I apologize to the nurse and said, no, let's talk about that. So important.
Thank you so much for this presentation and the good work that you're doing. I'm interested in impacts that you might see in the housing situation for this constituency.
Yeah, housing is such a challenge for people who are living without any credit history here in the U.S. or rental history or jobs with income. And so resettlement agencies are often, essential because of the relationships that we have with landlords. Sometimes we end up in the role too of trying to help other people refer to us through other organizations who maybe are coming as new refugees that need that sort of trusted connection. Yeah, and often the housing that we're able to find, that's just, um, not, not the best. And often some, like a lot of issues along the way, they need to get worked out, and it's hard to know what families want, at the time prior to arrival in terms of, very small and something that's gonna be more affordable for them, or 4 bedrooms, so that everyone. Yeah, super, acute problem, the housing, shortage of affordable housing.
Thank you. This will be the last question.
Thank you so much for all you're doing. So I'm actually very concerned about the resources available, and it might be applicable more to the asylum seekers, because oftentimes, despite the fact that most immigrants know these resources are available, but they're kind of existent because they don't know if it's going to be counted as public charge. So what are you doing to that? Like, it's another thing to know there's resources, but it's another thing to have the fear to take such resources, because you don't know if you take it up, that would just be like somebody once advised me, before you call 911, call people. Because when 911 come, you're gonna pay later. So why should I be feared to take resources? Because I know if I just come back and bite me. Thank you.
Thanks for that question. The public charge rule is so confusing, and unfortunately, I think has prevented so many immigrants from receiving benefits they're entitled to and really could be saved for them. So there are a number of Illinois welcoming centers in Chicago and the area that provide services specifically for asylum seekers. And I think that most of them are pretty well equipped to help talk with asylum seekers about that. ICER has some great handouts, that are pretty clear in terms of, what is, it could be potentially considered public charge. Although there are nuances that are rarely clear for anyone. So I think those are some of the things that we try to do, just be as familiar as we can be as we're helping people to apply for benefits with, what is safe, and clearly explaining if there is a risk so people can make a choice.
I'll just add something from the healthcare perspective. So we have, at Tapestry, we have some benefits navigators that help connect with patients who might come uninsured but eligible, and can really meet with them one-on-one to explain everything, and reduce that fear and support that enrollment. Because of course, it also helps us sustain programming, right? If we get reimbursed for it. And also some community outreach. So we're involved in some health equity zone work in Rogers Park, and connected to the program in West Ridge, where it's really about figuring out how to encourage populations and communities to engage in their own healthcare and access the resources that are available, and also link them to care, and really being out there in the community is super important.
Wonderful. Dr. Adamji and Rebecca, thank you very much for taking the time to come here and share your expertise with us. Will you join me in thanking our potential team?
Thank you again. Now we will commence our workshops. If you look on the back of your name tags, you will have 3 different colors. There is a round 1, a round 2, and a round 3. If your round 1 color is red, please make your way to 206. When you leave out of these doors, you can make your right, and 206 will be there. If you don't have a color, you can go to our poster presentations, or you can check out any workshop that's not been full yet. Yeah, sorry. If you have a blue color for your first one, you will be into 13. If you make your way out and make a right and another right, you will see your classroom. If your first dot is green, you'll be making your way to the Greater Lawndale La Jolla, which will be into 19. When you leave out the doors, you make a left and then you make another left and another left, and then there will be stairs for you to take.
But they don't know what room number is marked, so we need to put some order on. Can you open it for the data? That's what I'm just projecting it apart. So if I come up. I'm gonna just.
Hello, everyone. Are you all enjoying yourselves? I don't know. Are you really enjoying yourselves? Well, that's good. My name's Cecilia Macias. I serve as a director for the Office of Diversity and Inclusion here at the School of Public Health. And when you all registered for this wonderful conference, you selected what workshops you wanted to attend. And if you registered a long time ago, you're probably like, I don't know what I registered for. So this is where these color codes come into play. All right. So if you flip over your name tag, we have given you your first and second selection. Now, if you'll see in the other side of your name tag that there is a color orange. That is for poster presentations. So we have a ton of students, community members, faculty and staff who submitted abstracts to present today, and they're right on the other side of this. That's orange color. And my wonderful and amazing colleague here, Angela, has put in here what each color means. So you're like, I don't know what it means. What does it mean? Red color is room 206. So that means you picked collaborating to improve health equity. Blue color is gendered racism and power, building relationships in Black communities. Yellow is health practices for religiously informed care, which is gonna be moved here. So if you picked yellow, come here. And then green is Greater London Loteria. Now, if you're like, I really wanna check this out, that's okay, check it out. Just go to the room number, refer to this, and go to that room number there, okay? So, but that said, if you wanna hear from the collaborative health practices for religiously informed care, stay here. If not, go and learn. We're so excited for you, and you are dismissed. Yes.
Sure. Did you set up the